together.
Coming together is right. Got frames up. Oh, that's nice.
You're ready to go, John?
Okay. Okay. I'm gonna go ahead and call the monthly Kern Valley Healthcare District Board of Directors meeting to order at 2 o'clock. The first item on the agenda is the approval of today's agenda. We have 3 board members here today, so is there
Yeah, make a motion to approve it.
Okay.
As presented.
by Director Parks,
I'll second.
second by Director Elliott. All in favor?
Aye.
Any opposed? Okay, passed. Okay, I'll do the flag salute today, and John will do the invocation if you want to rise to join me. Please place your right hand over your heart and repeat after me. I pledge
Allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Lord, please help us to service this community, keep all of us here safe, and help us to do a good job for the district and the people in this community. Thank you. Amen.
Okay, the mission statement is on the agenda for those that want to see it. Item C is the public comment portion of the meeting. Is there anybody from the public that wants to make a comment this afternoon? Anybody from hospital staff? Once,
Somebody here.
going twice, yeah. Okay. Item D is the consent agenda. These are routine and non-controversial items. Director Elliott did share that he wants to pull items 19 and 21. Is there anything else that needed to be pulled or any questions that needs to be asked or clarified? Okay.
Never mind. Okay. We accept it as presented with the.
The 2 that are pulled. Okay. Was there anything else, Director Elliott, that you wanted to?
No,
pull?
I'll second that motion.
Okay. Moved and seconded. So Nick, all those in favor?
Aye.
Am I the only one? Gene?
Aye.
Okay. Okay, any opposed? Okay, motion passed, okay. And we'll move items 19 and 21 to, would that be old business, Scott, technically?
New.
New, I'm sorry, new business, okay. Okay, John, you're up for your CEO report.
Okay. We've been talking about the wound care program now for a while. But we said it was too good to be true. It may be too good to be true.
Oh, shoot.
We've been doing, we'll never lose any money on the Medicare patients because it's cost-based. However, we are trying to figure out how we're going to make some money on the managed Medi-Cal. The cost of their product is unbelievably high. And I think they're taking advantage of some of these critical access hospitals because they are getting paid a lot, but at the end of the year on the cost report, you need to pay it back. So I was talking to the CFO at Surprise Valley, who they're using as kind of their show pony, and he wasn't hardly even aware of the fact. Said, you're gonna have to pay this back probably. Said, don't spend it. But they were here today. It's doing great things for our patients. The one is already healed, and she's only had two procedures. So it's a good program. We just need to figure out how we're going to make it work. And we're not going to make it's not a savior like they said. I think they're overselling it, but we're not going to lose any money on it.
What is it exactly, John? What do they do?
They sell us this product, which is wound carriers, and that's they sell it by the square centimeter, which is really small.
Uh-huh.
And so they pack the wounds, they clean the wound out and pack it. And it's right now, so far, we've been working on our SNF patients who have wounds that don't heal.
Uh-huh.
So it's working well. I mean, it's a great product for the patients and for our community. And that's why I want to try to make it work. But it's just not everything they said it was going to be.
So do they actually administer it?
No, we do. Todd does that. Todd is going to do it, and Dr. Spahn will do it eventually
Is it something
too.
we're just buying from them?
Yes, and
So
that's how they make their money. They mark this product up like crazy. We bill it out to Medicare, and we get paid cost as usual for Medicare patients. We pay them, and then really there's not much left over for us.
Oh, it's not the end of the world. We're getting paid to actually administer and use it and make And our patients are
Our
benefiting.
patients are benefiting. That's the most
Really
important
great,
thing.
yeah, right.
Right.
So even if we broke even, it wouldn't be the end of the world.
Well, that's what I'm saying too. I'd say if we
Cool.
break even, I think we're happy, but that it's for Medicare, we'll always break even. For managed Medi-Cal, we're trying to determine what they're gonna pay on this. And right now, we're getting top of the line product, but there's another, they just told us this after, there's another product that's a little bit less.
We need to make more because we're down to 3 board members.
Oh. So that's what we're working on. They were here today. I was talking with them. We're gonna work on them to get the bills out. We haven't even billed anything yet. But they have a kind of a specialist that we had a phone call with the other day, and he's gonna talk with our billing people again.
Does it go bad or anything? Could we lose money?
No, as long as we keep doing Medicare, we will not lose anything, buddy.
Okay,
The worst will come out is breaking even.
that's.
And what I'm trying to do right now is figure out how to allocate a few more expenses to it by some of the, and that way that'll boost the expenses we're already gonna pay anyway, so that'll be our profit margin.
Well, I
right
could pick it up for it and I walk slow.
there. So so that's where we are. We've got a couple contracts
Can I
here.
ask you questions about
Yeah.
that?
Yes,
So we had kind of talked about as the board at one point, kind of relying on this wound care maybe to bring in additional revenue to help us address the shortfall that we know is going to be coming in a couple of years. So doesn't sound like it's going to materialize if we're just going to break even on it.
the only way that'll help is if we can start getting some admissions, and that's really one of the reasons we brought this in, is to try to get some more swing bed admissions or even acute.
Okay.
And that's kind of, and then maybe some other ancillary revenue from x-rays, lab and things like that, or PT. So that may still materialize, but as of yet, it has not.
So do we enter into some kind of contract with this organization?
No contract.
Okay. So if we want to
But
use
want to
a
stop
different
it?
product or,
Well, that's what we're doing. We're trying, Christine right now is looking for comparable products, and we've already found some. They're about half the price of what they're charging or less. We just need to make sure that they were talking apples and apples. And she's looking into that right now. And I think we have a meeting with Smith and Nephew, who is a supplier of these types of products. And we're going to see if we can, because that's the only way we're going to make money on the managed Medi-Cal, because managed Medi-Cal, it's not based on cost, it's based on a fee schedule. So we could charge them whatever we want to charge, but they're only going to pay a certain amount, like a DRG in big hospitals.
So the less we pay for it,
The better it will be.
keep the
And
difference.
right now, we're staying away from those types of patients until we figure out whether or not we can actually at least break even on them.
Okay.
We'll just do Medicare. Like I said, we can not lose money on Medicare. It's cost-based. And if I can get a little more costs in there, we can make a little money on it.
all right. Thank you.
Any other questions on the wound care? Okay, we've got some contracts up here. One's the Bakersfield Indian Project contract. We talked about that last time. They've got about 54 patients right now, but they can go up to about 200 patients. So that'll be a windfall. It'll be a good thing for our clinic, I believe. And good for them too. I mean, they're going all the way to Bakersfield right now, and they want to come here.
And Bishop.
And
Bishop.
Bishop, right? And they approached us. They approached Andy working actually, and that's the same thing with the UHP contracts. They just came to him. That's going to be more patients coming into us too. It's not a great contract, but it's a better than cost contract. It's about 115% of Medicare, I believe, and that'll help us. And that's really about a good contract you can
Good
get.
deal for them,
It
right?
used to be these payers would negotiate with a percent of charges contract, which was great for all the hospitals. But now, ever since COVID, it's been fee schedules, just like Medi-Cal used to do. I mean, Medi-Cal was even based on cost a few years ago.
Where are they getting their money from?
Who?
I guess you can
Indians?
say Indian.
Oh, the
but
Indians?
It's in here.
I have no idea. I don't know. I don't know where their money comes from.
Okay.
Probably.
What I'm wondering, is it gonna dry up and we're taking care of them, we have to keep taking care of them?
If they don't pay.
They got no money.
Well, they're not, the primary person paying for them is actually commercial insurance. If the commercial insurance doesn't pay, then we go to India.
Oh,
No, whoever their patients have insurance, whatever insurance their patients have, will pay primary pay. So we're good there. But then if there's a copay, that's what we need to figure out. But this is going to be a pretty good, it's good for the community. I think we're not going to lose money on this either.
It's gonna help them.
It's going to help them a lot. It's saving them from going all the way to Bakersfield. The sniff, the fix up, Bob's people are doing a really good job. I don't know if you guys have been in there. We still have a ways to go. But we,
Waiting on the code base.
right, we're waiting for that. That's where the company's gonna come and do that. The floor is almost done. We got a few spots that still need to be done. We have painted all the doors and the door jambs. And what's gonna happen, we're probably gonna we're gonna have to touch up the walls because we did the doors and the door jambs look so good. The walls don't look so good. That's the problem.
The new corner guards shipped yesterday.
Right. What those are gonna do is frame our, I don't know if you guys seen the murals that somebody did. They're gonna make those stand out a little bit more.
Do we do in-house painting on the walls or do we?
In-house.
In-house, everything's been in-house. So, well, actually the floors.
The flooring, we're using Bakersfield flooring. We're doing inset patterns like we did in acute care,
Mhm.
and it just lifted.
It looks great,
So
yeah.
much better.
How about
Bob designed the patterns too.
How about the shower?
The shower,
Mm.
move the wall over on the shower will require doing a OSHPD permit to tear out the wall, build a new shower pan, move it all over. I'm estimating the cost could be 75, 80,000. So we're holding on that right now.
Do we have to have that?
No, we don't. It was for patient, not patient safety, but employee and patient safety.
The shower has worked for 30 years.
Right. It's
But
just,
it would be nice if they had a little more elbow room to get around the patient, when it's a larger patient especially, to get around and help them bathe. So they wanted to know if we could move the wall over. Well, the problem is it's a pre-made fiberglass shower pan. So if I tear out a wall, then the shower pan's gone. So then we have to build an entire new shower pan, wider, a new wall, et cetera. And I double checked with my OSHPD area compliance officer and he said, permit.
so we're gonna hold off on that for a while.
Don't check with them on stuff.
So we will maybe eventually do that, but let's get the rest of it done
Yeah.
and see how that looks. And then maybe it takes training of our nurses a little bit differently so they don't get hurt on
Or
their,
we might do it as down the road as a.
Right. we get a windfall of
It would
money.
be, we have way more room than we need for the Parker tub. And so it would be nice for the shower to be bigger.
Could we just put an additional shower? Cheaper?
There's not enough room for an addition.
Okay. Could put it down next to Heidi's office.
The SNP rate, I'm trying to get that up right now. Our rate is kind of low because our expenses are lower than other people's, which is a good thing, but it's all based on costs. So we get paid 503 and the highest you can get is about 711. I'm going to try to get somewhere in between there because even $100 extra in per diems is worth about $2 million to us on 20,000 days. So anything we get there is going to be even $50 is $1 million. So
Is there a breaking point or is it gradually?
well, it's all based on cost. So I need to look at how we're allocating our
Is there a
over.
breakdown? There's a steps though.
There is, but the limit is $711.
Yeah,
That's
like
most anybody can
tax
say.
bracket, sometimes if you.
Oh, no, different than that. No, it's all based on, you can go up $1 if your costs go up $1 or $10, whatever it is.
Everything works out
Yeah,
evenly, so
yeah.
it wouldn't help us to pay our nurses more in there.
So can we scrutinize that overhead cost, that costs that are being allocated to the clinic, costs that are being allocated to the lab,
That's what I'm looking at. But
to maintenance, all that? And
the only thing is if one goes up, the other one may go down. So I need to figure out, is it worth raising the SNP rate if the inpatient rate goes down? Since we have so many more SNP days and inpatient days, it's a juggling because there's only a finite pool of expenses
okay,
and you allocate them. Right now, I think we're allocating a little bit more to the inpatient, so our inpatient rates are up. But since we have so few days in the inpatient, it behooves us to get the SNP rate up instead of the inpatient
our
rate.
lab prices are so high, it might be an opportunity to get those down.
Well, we're looking at that too. We are in line with other hospitals, but we'll never be able to compete with LabCorp. That's what I mean. It's $20. We're 1,000 probably for
Right.
the same thing. But we're looking at that. We did. Coral Health came in and did a comparison of all that, and so we're looking. It's just, I mean, it'd be a good thing for the community. We could advertise and say we're lowering our lab prices, and eventually we probably will. We're also looking, we're also looking to, I was just talking to the nurses and Sally today about starting a GI program in that space, surgery space, since it's such a big space. We have a doctor I'm going to try to meet with either next week or the week after. And he's Dr. What's his name? Dr. Baika. He was up here before And he went away for a while. I think COVID was one of the reasons that we stopped doing this whole program. But we have the space, we have the equipment, we have the people. So there's no reason for us not to do it. We have the demand for it because people have colonoscopies down in Bakersfield where we could keep them up here.
Yeah, he's good. There's no reason to go
Yeah.
down there.
I
Right.
remember him. Yeah.
He's very good.
Yeah, so he's almost ready to retire, I heard, so.
Yeah, he's getting older.
Well.
No, he's almost 50 years old.
So I will talk with him and hopefully be able to set something up with him to start this program. I think it's a win-win for everybody.
Yeah,
Make
he's
money.
great.
That's good for the community.
Don't we have to have an anesthesiologist
So
also?
he said he's got one.
Oh, okay.
That's still negotiable.
He's my doctor.
Oh, he is a good doctor. So if we can get it, they say that he's got a CRNA that can come up here. The problem was before our other CRNA retired, I think.
Yes.
Plus the other one won $1,800 a day, which is a lot. Unless we can put, they said they can do 20 procedures in one day. I don't know if that's true, but they said they're pretty quick.
He probably does most of the people up here.
Oh, really?
It's like,
Yeah.
wow.
Back in the day, the one challenge we would have is people would cancel on the day of the procedure.
Right.
So the volume, we thought we had the volume where it needed to be, and then all of a sudden several people didn't show up. So then it limited it to some extent, but it still was really nice. I mean, I've had it done here and I've had it done in Bakersfield, both by Dr. Bucket.
Oh, okay, good. We are working on about 3 audits right now. We've got a Medicare audit going, a Medi-Cal audit going, and our usual financial audit by TCA partners. And Amy is doing a good job on getting all that ready. And we're just waiting for, I mean, the one's almost done. The Medi-Cal audit is almost done. I don't think anything's going to happen that. We just got a review of our Medicare audit from 2024, and we've got money coming back. But now they picked us for a whole audit, so our cost report preparer said, put that money aside. It may not be yours quite yet. So that's what we're doing. And that's, the cost report is due the end of this month. Amy has got just about everything to him, and our cost reports we usually got a small receivable coming back from that. That's all based on Medicare.
John, I'm back to the audits and
Uh-huh.
the one place that we've got that's giving us information we're working with on the Medi-Cal or the place we just hired. Are they Medicare or Medi-Cal?
Which place?
We approved it last month.
I don't know. I don't know who you mean, Chief.
Which one are you talking about?
The one that's gonna help us with Medicare and Medicare billing. Yeah.
Oh, that's the denials. That's Nagel, PM Nagel.
Yeah.
Yeah. Yeah, he's what?
SCA, was that the other one?
Oh, SCA. Yeah, SCA was the other one too.
They help us to where we get all the money we can.
Well, not really. It's really on us. We do that pretty much. What Nagel's doing is he's looking at the denials. He's going to try to get us some money from the denials. We have a lot of denials and we are understaffed in the business office, so we're not able to work those all the way. But he's already rebuilt some and gotten us money. We're paying him about 14,000. He says he'll get us at least 50,000 back, and probably more than that. So,
But you said it's on us, we're doing it. Are we doing it? Do we have enough help or do
Oh,
we
yeah.
need more help? Do you more education?
no, we're used to it.
Get an outside observer?
No, we don't need that.
Okay,
Really. We're fine on the cost report. Amy and I can handle that. I think Amy's doing most of the work right now.
Getting it done.
We're
Like,
getting it
it
done.
can be so complicated.
Well, it is, but
Around and
our Medicare is only about 20% of our business, as opposed to other critical access hospitals, so it's closer to 50 or so. But that's why, like I said, we have a small receivable. Right now, what I'm looking at, like I talked about earlier, is trying to push that overhead around so that we can get our SNF bills up, our SNF rates up, but we'll see. We are looking at our employees' wages. We're using HASC, which is the Hospital Association of Southern California, and they have ranges for every type of job description. Yeah, we worked on some, excuse me, which they were about 2.5% raises for everybody. That's going to be the net. We've already given 4.5 actually, but we've already given it 2.5. We got another 2 coming probably. So that's
It'll be 4.5.
4.5. That's what we agreed on the budget, 4.5%. We're gonna be right
They
around.
budgeted for, but they're looking at the salary ranges to see which groups are below what the market is and which ones need to be brought up. It doesn't apply across the board to everyone.
No,
Okay, so is a committee for, who decides the salary ranges, who's,
the executive team is all working on it.
executive, because they always end up getting the most money,
Who's that?
the executive team.
That's not true, Gene.
So the executive team comes up with the salary range and then they present it to the board and the board approves it and then you post it on your website.
Right.
Okay. When do we look at that? Because I don't remember looking at salary range last.
Yeah, I think we presented it about maybe 6 months ago or so. What was that?
Okay.
No?
I think they brought up like changes to certain positions. You probably remember when we raised up the CNAs to kind of.
The CNA, I
Right.
remember that.
And we're looking at
So,
the,
right, special ones like that, but like our salary ranges as a whole, we not bring that to the board.
Yeah, we need to. I'd like to, because you want to see it in balance, and not that we don't trust the executive committee, but we don't.
we're
It's not our-
transparent as you want us to be, Gene.
Yeah, we want to be fair.
Yep, so do we. Okay, no problem. Nurse, we're working on some nurse training right now, Mark.
I'm sorry, you
Go
got that, Heidi, that we want to put it. Right, okay, thank you.
Mark is working on nurse training. We're thinking of bringing some outside people in to help train some of our nurses, or even trying to work out something with some hospitals in Bakersfield where we can send them down there to train. But that's really just starting. We have not really got anything definitive on that yet. And Greg just gave us some good news. Looks like we may have a doctor for the clinic. We are in the running with some other facility. We don't know who. He's gonna come Wednesday. We'll take him, show him around. He hasn't been up here yet, correct?
He's done some work in the valley in the past. He's traveled around a lot. So has a passion for our area. He really enjoyed it when he did work here years ago. So looks positive.
Trying to come up with a fair salary for him and probably be a little bit of a sign-on bonus too, maybe 6 months and a year. That way we make sure he stays for a while. But we need another person in there. We are losing somebody and we're losing
Nurse practitioner.
nurse practitioner. We're losing.
sure.
What's her name? Megan?
Yes.
Megan, we're losing. She's going to Ridgecrest.
Is there a reason why she's going to Ridgecrest? Are they paying more or?
She's been commuting. She's worked in Ridgecrest for many years.
Okay,
and
okay, that's
she's in
good.
the community, lives there still, so.
We thought we had an NP to replace her. She accepted the offer and then decided not to come. So we have room in the clinic for another provider, probably for 2 more providers if we really want to, which is what we're trying to do. So we can get the clinic visits up there down a little bit because we're not accepting really new patients at the moment, I believe.
Into special situations, but it's a whole.
So that's limiting what we can bring in right now. And that's where everything starts as far as ancillary revenues and things like that. So we need to get us. And that's the end of my report. Any questions?
Any questions for John?
For Greg, are we taking new patients?
Right now, we're opposed to taking new patients, but in certain situations where we always are open to that. All the providers have pretty full schedules. My schedule is the most open. So if it's conducive to someone that can do a hybrid of telehealth visits and when I come here, and then we try to do that.
But right now, if I wrote a policy and put you down, the company will accept you as a provider. Are you closed, not open for new patients?
Right now, no.
Okay, well, that is really, really bad.
Yeah, well, hard to find providers. I mean, we've been looking, how long? We've been looking for a year almost now, huh? No,
Exclude the time from our other physician was here. We've been looking for 3.5 years.
all right, well, hopefully we found, we'll know Wednesday, we'll let it after Wednesday.
Okay.
We need to show them a good praise.
All right, John, woo them.
Let's try. Greg's already been doing that, I think, to get us to this point.
Good.
Greg and Miranda. Good.
And we have another physician that's really interested, but she's still in residency, so it would be, actually would be a good rollout because you don't want to bring two docs in like immediately and struggle to find patients for them. But so she would be available. She's very interested in our position too. She's available in probably August, July, August.
Yeah, that's great.
Any other questions
Any
for
questions?
John? John, I just had a quick question. Was kind of unrelated to your report, but we've been talking about different services that we can provide the community. I see Lisa's here. Maybe Lisa, you can maybe fill in a little bit if you want, but because you work in behavioral health. But so I ran into Heather Berry the other day, and she was talking about it's called intensive outpatient care. So it's like for like people that struggle with like addiction. They come in for like 12, 24 hours, but it's intensive and they're discharged basically after a certain period of time. But Heather was sharing with me that they have higher reimbursement rates for those kind of patients. Just thinking that it might be something to maybe look into.
We are looking into starting or enhancing our mental health program. Lisa has given us a proposal on that already. We are reviewing it. The problem with this, we don't have the staff to fulfill what you need. That's our biggest hurdle. Finding people who are either LCSW or even a psychiatrist. We may be losing our psychiatrist too. Where does that stand, Greg?
Tried to talk to Dr. Parker this week, but it's gone, so I'll reach out to him next week.
If he leaves, we're going to be short of psychiatrists too, which is not going to be good for us. Yeah.
Oh, he is here.
And currently, Thervita, their level 4 program is considered an industry outpatient program. I know one time, Chet, we talked a lot about that, actually, so I don't know how to pursue that or the contract with them and all of that. But I know that Thervita offers the IRP program through their substance abuse.
We actually met with Clarvita regarding the Suboxone program, and so we may have some affiliation with them down the road too.
Okay.
They provide a good service and they're close. And they are, I don't know if they're national. Are they national or just this area?
There's a psychiatrist that lives in Kernville and his practice is online. So I think his clients are all in a different state.
Really?
But he's local. I don't know.
We're talking to.
Yeah.
Let's see what happens with our Dr. Barber.
Okay.
But he's been kind of up and down for a couple months now, huh? Dr. Barber, wavering.
Say that again.
Dr. Barber's been kind of thinking about this for a couple months now, or at least.
Yeah, he hasn't made any decisions, thinking about transitioning his work and personal life. So I've had a good amount of conversation with them. So I'll be following up on that.
Okay. Well, let me give you the contact information for this local guy. I have no idea what his interest would be, but we're having a conversation. So.
Yeah, with the conversation with him, that's sure.
Yeah, because as we all know, behavioral health is a really huge problem in the community. So I'm just thinking of ways that we can, offer services here. I know at one point we had talked about, this is before you came here, John, but when we're having issues with the skilled nursing centers, we had actually thought about maybe trying to relicense part of the SNF into behavioral health. And I don't know of all the particulars that requires with the state and proper staffing and all that kind of stuff. But
it's an option for us. If we can't get the SNF filled with SNF patients, we could always try something like that. And there's demand for that definitely in this valley.
And I see Director Clark arrived. Your name tag is over there on the shelf. If you want to put it.
Appreciate y'all for accepting me after being late. Sorry.
Did you have any questions for John? You right along. Okay. Any other questions for John before we?
This is fish arrival day.
They're here.
And thank you, Lisa, for the.
Yeah.
Okay, we don't have any old business this afternoon, so we're going to go into new business. And item 1 is the pricing cap. John, did you have this on page 74? Did you have anything to talk about this? 74.
It's got a contract amendment is what it looks like, and I didn't understand, and I'm hoping you can explain it.
Go ahead, Scott.
Okay. So what happened is when Tim retired, he retired for medical reasons, so it wasn't a medical retirement or a disability. And so what Bryson did is, if you look at item D3, vesting percentage, this is what's being amended. So the vesting, it fully vests unless Tim was terminated for cause at any time. Before that, that for cause language was kind of squishy. So they just tightened it up and just said if you're terminated for a cause.
Okay. If he said, well, I'm sick, you can't work anymore, and he goes to work next month, then that's not right.
Yeah, I don't think he's doing that.
Well, but,
If he did that, then we could address that, but he's
okay,
not
then,
doing it.
okay, so this won't squash our ability to,
No.
to deal with it. This is not gonna cost us any more money. We're not going to,
Nope.
by signing this, we're not gonna be committed to bailing anything out.
Nope.
There's no reason not to sign it then that I could see can be,
No, this is memorializing what the board collectively discussed at the time of Tim's retirement. This is just putting that into writing.
we won't have to look at it again.
Other than the annual allocation of our.
I mean,
Right.
our
every Christmas, I'm
revenue,
happy to hear.
Yeah.
And I make a motion that we accept it. We don't like, I
Thanks.
think it's, but we have to do it.
I'll make the second.
It's been moved by Director Parks. It's been seconded by Director Elliott. Any discussion, anything, Director Clark? Okay.
No, sir. Thank you.
Okay, all those in favor?
Aye.
Any opposed? Okay, that passes. Item 2 under new business, this is the, it's another amendment for the emergency department agreement for Dr. Bowers. That's on pages 75 and 76.
This was agreed to by Tim in the past with Dr. Hall to give Dr. Bowers, this is kind of a preliminary program for him, but he's done a great job for us. He gets nothing but rave reviews. If we lose him, we'll be paying $400 for a locum. And the last locum we had was not very, man, we had big problems. We got another locum coming this week, I believe. But I think we should agree to this. I think we're getting out cheap with this. I think he's well worth it.
I make the motion, we accept it as presented.
Okay, there's a motion
We
by
have a lot of choice.
Director Parks. Is there a second?
So this gives me heartburn.
But
The contract, his contract, he signed the contract for 1 year. It expires in February when he's getting a mid-year raise. And this is not something that the board agreed to. It may be something that Tim said he wanted to do. The board objected to this all along. And so justify it.
I think
The guy signed the contract.
I agree. I think he came in under market. We got him in under market, but I think that in order to make him happy and have him to stay, this is what it's going to take. And if he leaves, we've got a big hole in our ER, and we're going to have to fill it with. We can't find any more doctors right now.
Okay.
I don't like
What do we
it.
do?
I don't like it either, but I don't think we have a choice.
If he leaves, can we recover any money from him for breaking the contract?
Well,
They have a 60-day.
that's
Yeah.
a question.
Oh, okay, there's a 60 day out,
It's a
okay.
2-month, 60-day out clause. So
I think this is still under market because if we bring a new person in, it's going to cost about probably $350.
So the fact is February don't make any difference. It's,
Yeah.
60 days out. It's-
Right.
So are all the other doctors gonna come up and say, hey, we want more too?
No, I don't think so.
Okay, we'll see, huh? I'll make the second.
Find it one at a time.
Right. That's one fight at a time. So,
Well, second, James motion.
Seconded by Director Elliott. Any other discussion or comments? Sir, all in favor?
I
Any opposed?
begrudgingly.
Understood.
Yeah, understood.
Item 3 is the population health building. This is just a discussion. John, can you-
This is,
it's the population health,
oh,
Oh, Billy.
yes. We are paying rent to them. We just signed a new agreement, but I think if we buy it, it'll be the same expense, but it'll be ours after however many years we decide to pay. I think it's a good idea. We can also depreciate it then and get some money back on the cost report. And I think we're just kind of throwing money away by leasing it. If we continue to lease it, we're not getting rid of the building. We don't have anywhere else to put the people that are in there. So I think it's a good idea to buy
The
it.
building and planning, we agreed to get an estimate on what it
Right.
costs.
And we have not yet. It hasn't come through yet. Yeah, we need to, we still need to do that.
Yeah.
Yeah.
And
And I've spoken to her and she's willing to abide by whatever we find. she's very
they'll be
easy to work with.
reasonable. They might even donate part of it back. So
Oh,
they're
that's-
really good people.
So willing to carry.
Carry the
Yeah,
note.
They will carry, we don't have to go get a loan for it.
No, they'll carry the note too, just like they did on the clinic.
Well, bring us the numbers.
We'll reach out to them and have them.
Yep.
Yeah.
And what was the last one? Last one was like 400,000, I think.
The last appraisal was probably 12 years ago, and I think it was like 425. They had sent back to us, but
Yeah, it should be less now than it was then.
Is it really? It's gone
Oh,
down?
yeah, yeah. Since you moved here, Don,
What?
since you moved here,
I brought that really down. Thanks. Good. I recommend that we buy it. I mean, I think it's a good deal.
let's see, yes, let's see what they're gonna do.
Getting
But
a
we-
proposal.
Yep.
Yeah.
okay,
Yes, yeah.
Yeah, I think it's a wise decision at
Yep.
this point.
Yeah. Let's see what the numbers look like.
Right. The only problem is it's not OSHPD certified, so we can't really do any. What we could do is rent it out to other physicians, specialists.
Yeah.
And collect rent on that like that. And that's a good, and it provides services to the hospital. We may get some ancillary revenue out of that too.
We're using it for the mental health.
We're using it for population health and some office space. Lisa, I think Lisa's office.
Could we use more
Nina's
for more?
office
Can we make more money
Nina's
if we
office is
get?
open
Nina's
at
over
8
there.
hours.
So if we get rid of the building, we really have no place to put those people.
Right.
We're stuck.
It's being well utilized.
Right. And like I said, we'll get depreciation out of it if we buy it.
Exactly.
One more question on buying the building. We spent all that money to have that damn thing put in there. Can we go ahead and run the electrical from the same unit over there pretty cheap?
You're talking what, the generator?
Yeah. Should not be a problem to run another.
Yes, I believe that we could add a transfer switch on that building because the generator is big enough to do both buildings.
Couple $100 for transfer switch, and I could do that. I could do that.
I'll hand you the tools.
No, just
spent
call
big
it.
bucks for steel.
It's 3 houses down. It'll just come.
By the way,
Then he's gonna run the cord over.
when you guys think the northern lights are going, it's really.
That's another good thing about buying it. We can,
Yeah, if.
the electric will be pretty cheap.
If we had something going on in that building that was needed to be there on outage days,
Right.
I don't see why we could not have.
And Jean, can I just clarify that currently the program, the way, the capacity that I use it in is for the QUIP program, the grant funded program.
Right.
Myself and the staff, you had mentioned that I was using it for mental health. I'm using it for the grant
Okay.
funded program.
Okay,
Just
for
to
that,
clarify.
that's related to mental health, though, right? The grant, can you explain then what it
Population
is?
Health Department is, the Population Health Department, the
Yeah.
grant that I oversee
Right.
is for preventative care, for preventative health, that we work closely with the clinic.
Oh, I thought it was something to do with
Yeah, so I just wanted to, you had mentioned that, I wanted to,
preventative health.
yes.
We get about $2.5 million a year for that quick program. And it's gonna be more this year because we're adding another metric.
Cool.
So Lisa, you don't see patients there in that building?
No.
Okay,
no.
I didn't. I thought you did
You
too.
can't because it's not OSHPD certified.
But I do have my QUIP, the grant staff is located, myself and 3 staff members there that help with QUIP. that
What do you do exactly?
are, in the building or as a grant manager? But I don't,
No, What do you do for the money we're getting to $2.5 million?
We work closely with the rural health clinic to track patients that are assigned to the rural health clinic and help them get their preventive health care needs met through our clinic. We increase services over there. We support the patients. We do a lot of reporting.
There's certain quality measures you have to adhere to.
Yeah, there's,
So we get to $2.5 million. How much do we pay out for help? Or how, do we make a profit on that $2.5 million?
Oh, yeah. I mean, but how much we pay the people you're asking?
What do we make a profit?
Oh, yeah.
Getting at?
Oh, yeah.
Is this related to the building
Yes.
in the purchase
Yeah,
of the
they're in the building.
building?
Yes. Yeah, they're in the building.
Right, but the topic is, are you gonna purchase the building?
Oh.
Yes, it is because of the occupancy and what we could do. So we don't have to have it compliant.
No.
To change the plumbing, air pipes in that building.
If we were to open a clinic function,
Yeah.
we could not do it.
Okay, my question the only thing that could make it compliant is the ventilation. Is that, it's
It's the
plastic.
it's the sewer piping, it's the electrical system and the ventilation.
the electrical?
Electrical in patient care areas of clinics has to be in conduit. And it's not. It's just regular.
Okay.
It's just regular Romex.
Can be grandfathered.
I got the existing clinic grandfathered because I went down when we did the expansion on the clinic. I met with CDPH and I explained to them, they said, well, you're gonna have to make it OSHPA 3 compliant. And I said, okay, then you're okay with closing the only clinic in the valley for an entire year. They go, well, no, that's not acceptable. I said, so what they did is they did not require the architect to send them a thing that says this meets OSHPA 3.
So we
So
can
the
use it.
existing clinic does not meet OSHPA 3 in the areas of the clinic that were existing, but it does meet OSHPA 3 in the areas that we expanded.
Is there any way we could bribe somebody?
Nope.
But we could possibly use it for more of what? The type, office type
We can
stuff.
use for office space, yeah, we could do that. And we're thinking about that too, what we're gonna put something else in
With
there.
mental
It's a big
health,
building.
telehealth where the patient doesn't show up. That's still,
It's a very big bone of contention between hospital-owned clinics and physician-owned clinics. Physician-owned clinics do not have to be OSHPA 3. But that's why John was saying we could lease space to a physician who operated a business and leased the space from us, so we would make profit that way because he does not have to be in an OSHPA 3 building.
also if we lease it to a physician.
Right. And we
It's
got
it's a very
special.
big bone of contention between hospitals. and the-
But Dr. Bike, I think, didn't he see his patients down here at,
You saw them at Dr. Lito's building.
okay,
So he would be one that we would have space to.
while he was here, but since Dr. Leho left, I think he went to Sierra down here. No? Okay. So he would use that, but he could possibly use that building.
Yes,
So another reason to buy it.
right, we can make some money off of it.
Okay, we're gonna go on to item 4. This was an item that Ross wanted to pull off consent agenda, was the foundation report. Auxiliary.
Yeah, I had questions for you.
Answers for you.
Okay. Thank you for the written report. It's always good. I had questions on the Bakersfield outreach. Is that, what's the outreach for? Is this for SNF? Is this trying to generate SNF patients?
Right, that would be correct. So I was trying to work with Irina just to kind of talk with the case managers to try to get more patients into the SNF facility. That's something that we're hoping to get up and running. So,
Great effort.
Yeah.
I definitely want that to happen.
He's putting together pamphlets for it right now.
Good. The things that I didn't see on here, maybe I didn't understand all I was reading, so that's why I pulled it off so we could talk about it. So in the community, we have, there are certain people in the community that for whatever reason, they don't like this facility. they've had bad experiences or by word of mouth. How are we addressing that? Is that in anywhere in this document, how we're addressing, trying to change our reputation in the community?
No, so it's not inside of the document, but I am actively working on it. It is a slow rebuild, and by me getting out there into the community, shaking those hands, getting in contact with people, slowly trying to rebuild that rapport, because there is a lot of distrust and a lot of negative feedback that I have gotten, which, comes with its bumps and bruises. However, just slowly rebuilding and just trying to get their trust back in any way that we can. And I think the biggest thing is definitely trying to do more community events, get more community outreach. So yeah, it's just a very slow rebuild.
I don't know if you've had the opportunity to actually see the care that's being provided to some patients. I don't know how involved that we let you be. But as a patient of the facility, it's great care. And so I'm hoping, I know that we have an effort now to get patient testimonials and provide that. I'm hoping that telling that story changes some minds or turns people's heads.
Absolutely. And, like I've explained to John and everybody else, the biggest way to reach people or broader audience is all the social media. And so just recently, actually, we had our first big patient story. Everything is very compliant. He's more than willing to be on video. He is a little bit older, so I have to work around his schedule, what works best for him. But he submitted a great patient story about him being at physical therapy and talking about the staff that's inside of there as well. And we're going to definitely utilize that on our social media platforms, on our website, spreading more awareness.
Yeah. I hope those opportunities come up more often because I think it carries a lot of weight, especially if we can share it on social media. The other thing, last month we talked about, some 300, maybe more patients that are covered by Kern Valley Healthcare that are going to Bakersfield for certain services. Is that effort to capture some of those patients somehow incorporated into your efforts yet?
Yeah, it is. I need to get those set of statistics. That's the biggest thing. I can't put out any information without any set stats. I got bare bones last time we met.
It's all we have.
Yeah, and it's in order for me to put out the accurate information, I just need those set stats. I mean, I can put something out and that'd be great, but people want to see numbers, they want to see results, they want to see that data, and they really want to see why. And I can't give them why if I don't have anything.
But how are we communicating to those potential patients that they can get their services up here?
Yeah, so that's a great question. The way that we are doing that right now is just kind of focusing on our said PT or focusing on our said pharmacy and putting in little tidbits of that information out there to the public, letting them know, hey, look, they understand that there's a closure with Rite Aid, so we're trying to revamp the said pharmacy, or we have new ways of taking your said information of the pharmacy, and so on and so forth. So just sprinkling little things that we can until I said get that data, then I can put that out there for everybody. So
okay,
focusing on different little parts.
Well, the stuff.
Nick, did we ever? Sorry, it's hard to hear, but
oh, it's Carrie. Where's
it's
that?
me. Hi.
Go ahead, Carrie.
Nick, did we ever put something out on social media because it's about Medi-Cal patients primarily, that these services that they're going to Bakersfield are free of charge up here if they have Medi-Cal. And so if I'm not mistaken, we put stuff on social media about that because that's directly related to what you're talking about, Ross, because that data you gave us was for those patients because they're going down to Bakersfield for Kern Valley Healthcare.
Yes.
So we put stuff on social media.
Okay. Do we know if we're reaching them?
And that's the hard thing. You don't really know if you're reaching them. I'm not doing geo-targeting, so I'm not targeting just this said area or that said area. I'm reaching out to the broad audience, and it's very hard because social media is.
It's kind of shooting in the dark, I know.
Yeah, but I mean, any outreach is something, and I want to make sure that we have something that looks uniform, looks good. Sorry.
So one of the other things that look like from the scant data that we had was that they're going down for radiology services like X-rays and CT scans. And I wonder if we can focus, at least provide some effort that in terms of outreach of, hey, you can get that up here. You can get those services up here.
Right.
We were talking about putting out something that exactly what we could do here as
Okay.
far as what is an ER and what is an outpatient service, so the community knows.
Okay.
Yeah, that's another thing that we're working on, Ross, is we've put together a document explaining exactly like what a critical access hospital is and the purpose for us being here. It's something that Nick and I have kind of been working on recently so that we can just raise awareness as to what services we have, specifically in the ER and other areas of service. Because there's doubt that people are saying, they don't want to necessarily come to the ER for, say, a broken bone or something because they don't think that we can do anything here, where in fact we're going to be doing the same thing that most facilities are, which is probably transferring to like an orthopedic or something like that. So we want to raise awareness as to what we are able to do so that we're making sure that people are coming and that they understand what a critical access hospital is.
Okay. Thanks.
Good.
Thanks, both of you. Appreciate it.
Could you do something as simple as running an ad in either the paper or the thing saying questions about Kern Valley Hospital? I have the answer. Something real simple. And the people that would respond to that would be someone who really had a question. You see what I'm saying? Maybe a problem that you could.
I get what you're saying. I think our goal is mostly to do like sort of like an FAQ type idea where we're answering those questions that we believe people have. And then we could put something on there. If you have more questions, you could reach out to us, but we want to provide the information to them.
Yeah, and just to kind of double down on that, Gene, I mean, honestly, like just spitballing right now, but I think the people would definitely appreciate somewhat of like a town hall, because yeah, there is discourse amongst the community that, KVHD is this, KVHD is that. Okay, so why not get out in front of them instead of talking?
Could we get the people that think they're upset or that has a problem? Can we reach them to get them to come to a town hall?
Yeah, I mean, it's anything possible.
We want all the people that don't like us
Yeah,
to be there.
Well, we used to do that before I was on the board. We did a few town halls. I mean, that was kind of when we were trying to do general obligation bonds, but we could probably, can we do something like a special meeting at the town hall and we kind of be almost like a community needs assessment, healthcare needs assessment.
Do that.
Correct.
Why not?
We put out the survey to kind of see, hey, what are people thinking? What can we improve on? There's been some few responses, but I'm waiting to see more. But I think that's the best survey of all. Is, hey, come up, we're right here, face to face. Let's talk. Let's figure it out.
Have you been through our skilled nursing? I know you're young enough that maybe you don't. Walk through there.
Yeah.
When you walk through there, does that make you want to get older?
Yes. I think the general answer is yes.
Cool, that's a good thing.
Nick, I have a question.
I have an
Are
answer.
you tracking the algorithms on every post you do to see what's working, what's not working?
Absolutely, absolutely. I'm trying to do, and that's why I'm trying to do this coordinated things to see, okay, if this is going to work. Yes, I do A/B tests to see if, all right, did this post do better than the other one? And the same thing with our LinkedIn as well. I want to see, are we getting more impressions on LinkedIn rather than on Facebook? And I try to track that. It is hard though, because I mean, previously we would only get like 1 or 2 likes, and now it's like, okay, we're starting to get a steady increase, but it's still single digits,
For me though, when I look at, I don't even look at the likes or the dislikes. What I look at is how many people clicked it and read it.
Right,
90% of people who read it, they're not going to respond either way.
right.
But if you know how many people are at least accessing it to read the data, that's going to give you a better feel of whether it's gathering attention.
Well, it's hard to do that on social media. You can only go based off of impressions as far as like clicks to see how many people are said click information. We'd have to, sorry, go ahead. But, it's more so of, we can only see if they're just looking at the information.
Give you an idea if you would. Talk to Spencer.
At
You
least,
can expand a whole lot of stuff that you probably are missing just a little bit of. Because what they do for our team, we have a lot of information just off that data.
Hmm.
And if it benefits you in this facility, that's what it's about. That's why we share that information.
Nicholas, at least you're tall enough, you can see the whole picture.
You know, it's a wild for a day, I would love it. I'm tired of it though.
So staff recommendation on this is just to
You were supposed to get the
review. I
chamber
guess it
yesterday,
doesn't
that showed
require
up for you.
action.
I know, I'm sorry, sorry, I went to.
I know, you went back to BC, I know.
Yeah,
Scott, this needs action, like it was pulled for consent.
It does.
Oh, it does, okay.
So I'll make the motion to receive and file.
Okay,
Second,
okay.
well, Fred's here now.
No, go ahead. Mr. Switzer.
Okay, it's moved by Director Elliott, second by Director Parks, to receive and file the foundation report. All in favor?
Aye.
Any opposed? Passed.
Thanks,
Nicholas. Thank you.
Thanks, Carrie.
And then item 5 was the number 21 on the consent agenda was the Bakersfield American Indian Health Project Agreement.
And I had one tiny little comment on 2 items.
Yes.
We have MRIs listed as something we provide and we don't.
Oh, I didn't notice a good catch.
So I thought maybe we should probably scratch that off.
Yep, thank you.
And then the indemnification section on page 58 of the packet. It's section 16 on that page.
Okay,
It's all covers them. It doesn't cover us. And typically, if they screw up, they indemnify us too.
okay.
So we tried to make that mutual.
You did?
Yeah.
Is that how it reads? Is that how it reads to you?
It reads one way. And so we sent it back as mutual and I guess they did not accept it.
Yeah.
Why?
We have not received anything back from them actually, so I don't know if they accept it.
Yeah, so there were changes that were made.
Okay.
I'm not sure the MRI was changed. I don't know if we got that, but I'll talk to them tomorrow.
How far away are we from could we get a grant for an MRI? Would it be worth it?
Probably not. There's not enough demand. An MRI machine would probably cost us $1 million.
Oh, yeah.
Can we get a grant for it? It's sometimes if you got a specific need, you can get money that you couldn't get otherwise.
Rumble cost $1 million on top of it.
Right. And we really don't have a
And for me, my head
No,
was,
we'd have to
We
build.
really don't, we'd have to build something probably.
I built the one in Bakersfield.
we couldn't,
And there's really not the demand for it.
okay.
Yeah, I don't think. I mean, we can look into it, but I don't think the demand is there.
Didn't Dr. Leo have one here for a while?
Not an MRI, just,
What was it, a CT?
no, it wasn't even a CT, it was just regular imaging.
Okay,
It was in the back of this building there, but it's super old.
okay.
Yeah.
I think
They should move it out.
it's one of those things that we need to stay on our lane, and it's just so big and so expensive that it'd never be worth it to us financially
Also finding somebody who could work.
to operate it. Yeah.
That's the other thing.
Yeah.
I'm sorry, I'm a little bit, is this agreement about an MRI?
No,
No,
that was just.
Service.
That's a mistake.
It had MRIs.
It was-
Oh,
We're gonna be providing.
Oh, okay, gotcha. I'm sorry.
So, John, do we need to approve this today or can we wait to see if we got a response?
We can wait. All right, you guys, we can wait. Let's make sure that we are indemnified.
Well, can we approve this conditionally or that,
I think it's a good thing. I think we'd like to get going. They'd like to get going.
subject to correction, yeah.
yeah,
Okay.
approve it with the corrections, and if they don't correct it, bring it back or is that,
Yeah,
Coker?
we'll do that.
Okay. So I'll make the motion then to approve,
Okay, moved by,
subject to those conditions.
okay, there's a motion by Director Elliott. Is there a second?
Yeah, but I think
Second by Director Parks. Any further discussion? Okay, all those in favor?
Aye.
Any opposed? Okay, that passes. Okay, item H is director's comments not on items not appearing on the agenda. We'll start with Director Clark.
I want to thank all of you for your patience. I'm sorry I was late today. I'm glad I'm sitting at the end of the table. 'Cause I'm sure I don't smell.
No comment.
No
God.
Spencer seen what I was doing. I was playing with fish.
Probably 100 buckets going at a time.
That's just, oh my goodness.
Pretty impressive.
It was fun.
He was just a lake fishing is what he did. He did put a bucket or two in his truck.
But thank you, all of you. Sorry I was late. Appreciate your patience.
Director Elliott?
Thank you for your community service. It's a wonderful project.
Absolutely.
Appreciate you doing that. I don't have anything other than, I already talked too much today.
Director Parks?
Basically just that Nicholas is out there shaking bushes because I see him once in a while from my office.
Of course.
I just want to ask, Heidi, is Director Elkana, is she okay? Is that why she's absent today? She's not in surgery or anything with her? Okay, okay.
Her seat is still warm. It was warm when I got in it. He's hot.
Yeah, anyway, thank you all for coming today, and that it was a productive meeting, and thank you for everything you do to make our hospital worthwhile, and we keep moving in the right direction. So with that, we're going to adjourn to closed session at 3:01. So y'all have a great rest of your week, and we'll see you soon.
So Spencer size fishing paper, your paper. Good
Question.
Yes.
Good to go.
Okay, we'll come out of closed session at